So I'm going to get right into it. We're going to talk about coronavirus. I'm going to try to heavily talk about the vaccine because that seems to be where all the questions are going. So going through the beginning, we know that in any of these emerging or re-emerging infectious diseases, we have the environment, the host, and the pathogen. There's not much we can do about the environment in this situation, or it seems like we can't do much about the host. But perhaps we can do something about the pathogen, and that's when we're going to talk about vaccines. And of course, we rely on our experts, both nationally and internationally. There seems to be a divergence of opinion when it comes to the World Health Organization and the CDC. I've never quite figured out why that is, but I think it's because the CDC is essentially setting policy for the United States and how our infrastructure works, where the World Health Organization really is dealing with all sorts of different diverse groups, and therefore they have different recommendations. For instance, they do not recommend remdesivir, which is one of the only antivirals we use for treating COVID. So there's a disparity in opinions going on here, but be that as it may. So, this isn't the only pandemic. We're going to get through this. We've gotten through measles and plague and smallpox, and we've gotten through the Spanish flu. We've passed other diseases that have been pandemics, but this is a problem. And, lately, looking at the tea leaves here, I'm a little concerned. I'm a little concerned about people letting their guard down. I'm a little concerned about variants. I'm a little concerned about what percent of people have been vaccinated, and we'll talk about that a little bit more as we get into it. But, for time immemorial, respiratory diseases have always been the leading causes of infectious disease death because you can't stop people from breathing and you can't stop people from asymptomatically spreading some of these diseases. So if you really look at the leading causes of death, it's always respiratory diseases followed by AIDS. Let's not forget about that. Malaria, we don't have a good vaccine or any vaccine. TB, we have a poor vaccine. And as long as we don't have clean water, young children and infants are going to die of diarrhea diseases as well as adults. But let's not forget when we talk about life expectancy. I don't know if you're aware of this, but in the year 2020, it was the first time in decades that the life expectancy in the United States dropped. It dropped by less than a year, but that's concerning. Look what happened during the Spanish flu between the years 1917 and 1918. The life expectancy dropped from 54 to 37. Now, we've only dropped a fraction of a year, and part of that's attributable to COVID, but a large part is also attributable to the epidemic that we have going on in our country called obesity, and the epidemic we have in our country going on called drug addiction and opioid use. So when you put that together, it's a little bit disheartening to know that the life expectancy in this country has dropped during 2020. So why COVID? Why now? Well, the major reason why COVID, why now, is because we have a lot of commercial and international travel going on. If you really look at the developing world, you can see that most of the world's growing and developing in billions. In the less developed world, where they don't have access to a lot of the things we're privileged to. But in the developed world, the population is stagnant. And because the travel and commerce going through all these countries looks something like this on the global air network on any one day, and you can get anywhere to anywhere in a 24-hour period, we're going to have pandemics from here on out. So then, all of a sudden, in December 2019, in the New England Journal of Medicine, the Chinese government announces that they have another outbreak of a novel coronavirus that we'll call SARS-2. And we know that started off possibly in a wet market, but be that as it may, it's a respiratory disease spread from human to human. And in 1 year, 2 year, 3 years time, we've gone from that to this. So although we call it COVID-19, you might as well call it COVID-20, COVID-21. And don't be surprised when we call it COVID-22. If you look at the guy down there with the thermometer on the bottom there, to me, that is the biggest false sense of security that exists. I mean, we all take care of people in the hospital. And if you look at somebody who's in septic shock, it's fortunate if they have a temperature elevation that we can measure as being elevated, maybe 2 measurements in a 24-hour period. Now, what is the transmission? There's all sorts of information on the internet, on Facebook, on Google. How is this disease transmitted? I put the arrows right there. This is a respiratory disease. Whether you want to call it droplet, which is the main way, 6 feet, whether you want to call it airborne, that's if you're in a closed space and a lot of people are breathing heavily or singing or shouting or screaming. For instance, in a choir hall, then it's in essence a respiratory disease. Yes, you can get the disease by touching a fomite, but that's very rare. Can you get it from an animal? No, animals can spread it to animals, but they don't spread it to humans. Can a pregnant woman spread it to the unborn? No. Can you get it from the fecal oral route, even though you can isolate a virus from oral? No, not unless you inhale the feces into your respiratory tract. Is it a sexually transmitted infection? No. Can you get it by a blood transfusion? Doesn't seem to have happened yet. So in essence, any of these things can happen. You know that anything can happen anytime. But this is a respiratory tract disease. I was watching a video from Spain that Maria, my wife, showed me, and it was the Minister of Health in Peru. And the Minister of Health was saying that asymptomatic disease is not transmittable. And the press who were interviewing her took umbrage to that, and they said, well, wait a minute. That's not true. Asymptomatic people with COVID can transmit it respiratory wise. And she sat back for a second and she said, well, let me correct that. Yes, they can transmit it, but only when they're breathing. Now, really. So in essence, this is a respiratory transmitted disease. And the problem is how many infected individuals will one infected individual create? And that's called the RO, the respiratory capacity. And it appears that for influenza, that's about 1.3 people for every infected person will become infected if they're exposed to them. For smallpox, it's a lot higher. The highest transmitted respiratory disease is measles. For every case of measles, you'll transmit around 18 cases. That's why you started to see a measles outbreak in the last 3 years in this country, because all of a sudden people didn't want to vaccinate their children for measles vaccine. But if you look at COVID, it appears to be for every infected person, they will infect around 2 to 3 others, even if they're asymptomatically spreading it. Now, the problem with that is not everybody who's infected is going to infect somebody else. There are super spreaders, and super spreader may mean that they're more symptomatic, they shed more virus, they're in a closed environment, they're around more vulnerable people, be that as it may. But on the average, it's around 2 to 3 people for every infected person will become infected. Now do the math. That means if we don't create herd immunity here, we're going to have quite the problem. The other issue is, well, how long do you shed the virus? How long are you transmissible? Well, it appears that you start to shed the virus a few days before you're symptomatic. You heavily shed it around the time you become symptomatic, and then it decreases. And this thing called the cyclic threshold, excuse me, basically looks at how many times you have to spin the machine to find the virus's RNA. The more you have to spin it, the higher number, the less transmissible you are. And therefore, we say that people who've been diagnosed with COVID 10 days after they've been diagnosed, and assuming they're no longer symptomatic, even though you may be able to find small amounts of virus in the back of their nasal pharynx, they're not felt to be, for all intents and purposes, transmissible, and you can take them out of isolation. So what are the stats? Global, US, Florida, Palm Beach County. Well, as of yesterday, there have been 141 million cases of COVID in a world that has almost 8 billion people. 3 million deaths in a world that has almost 8 billion people. The United States, around 10% of the United States has been diagnosed with COVID. Now remember, there's quite a few people who are asymptomatic or mildly symptomatic and never got tested. So this is around 10% of the country up until yesterday has been diagnosed as having COVID, of which around 560,000 have died. Now that's quite a few, but we're going to put all that into perspective. This is hard to see, but take a look. The US leads the world in the amount of cases. India is second, Brazil is third, and you can go down the list. If you look at the global deaths, we lead the world in global deaths. And then you can look at the United States, where the cases seem to be the most testing going on. Do you believe in California, they've done 57 million tests? In our country, there's been a test done for every 1.4 persons alive in our country. But why do we have so many deaths? Well, maybe we record them better. There's a lot of reasons, but this is the best way to look at it. First, you have to understand the difference between case fatality and mortality. Case fatality means you take the number of diagnosed people, and above that, you put the number of deaths, and you get your case fatality. In the United States, for every case of COVID, for all those 31 million people that we've diagnosed in this country, the mortality rate is 1.8%, meaning 1.8% of everybody diagnosed in this country, which is 31 million people, have died of that disease. Now, why do we have the most deaths? Because we're diagnosing the most people, because it's very easy to get a test here. Even in Spain, Maria's a Spaniard, we talk there all the time. You just can't walk into a Walgreens, an MD Now, a CVS, and get a test. You can't line up like you can line up outside Wellington Hospital for pre-op surgery and get a test. So our case fatality rate is actually quite low. Let's look at mortality, right? Mortality means if you live in the United States right now, what's your chance, whether you have COVID or don't have COVID, what's your chance of dying? Well, it's right here. I'm sorry, this keeps flipping back. It's 172 people out of every 100,000 people who live in the United States will die of COVID. So if you said right now, what's my chance of dying of COVID in the United States? It's less than 0.5%. Less than 0.5%. That's why you see certain people on some of these talk shows saying, look, your chance of getting COVID and your chance of dying from COVID in this country is so minute. Is it really worth disrupting the social and economic structure? Well, that's an individual decision. Let's compare that to some other countries here. Italy, higher. Brazil, higher. Peru, higher. Mexico, not quite as high. But if you look at the confirmed cases and the case fatality and the number of deaths per 100,000 population, let's see who beats the United States, right? The people who outperform the United States for those bad numbers are places like Italy, Brazil, Peru, Slovakia, Belgium, Bulgaria, Hungary, et cetera, et cetera, et cetera. Look at their case fatality compared to ours. Look at their deaths per 100,000. Why do they have less deaths? Why is their case fatality? Because they do less testing. Well, how about the United States as far as the ICU capacity? You hear about that all the time. Well, as of this period right here, 68% of the ICU beds in the United States were occupied, of which 9,000 were occupied with COVID patients. There are 86,660 ICU beds in the United States. Less than 10% or around 10% are occupied by COVID patients. How about inpatient capacity? There are about 750,000 beds in hospitals in the United States, of which only 47,000 are occupied as of this period with COVID patients. So you can see that although you hear about all these numbers, the hospitals are not overrun. The ICU beds are not overrun. How about Florida? Well, as of yesterday in Florida, there have been 2.1 million diagnosed cases, 88,000 hospitalizations, 34,000 deaths. You can look at by African Americans, other, unknown, and white. You can look at by non-Hispanic, Hispanic, and unknown, and you can see the different numbers. The median age of COVID right now in Florida is 40, which means the younger people are getting infected for a lot of reasons. A, they were not part of the initial vaccine rollout. B, they have less concern about wearing a mask. I go to this little private gym on Palm Beach where they're not all that young. Trust me. I was in there this morning knowing I was going to give this talk. There were 10 people. 2 of us were wearing a mask in a room that probably is no larger than 50 by 50. Now, what are you going to say? How about Florida? Let's look at the occupancy in Florida. Let's look at the numbers in Florida. If you look at Florida, the number of cases as of yesterday, you can see that the median age was 34 yesterday. Look at the median age in Florida that's going on here. Look at the percent of Florida of the cases that have been hospitalized and the amount death, 2% case fatality rate. Let's look at who makes up these numbers. Well, as of yesterday, the day before yesterday, on Saturday, I'm sorry this keeps doing this. It's something that I can't control. If you look on, as of Saturday, there were 6,400 new cases on Saturday. If you look at the net deaths, you can see that the majority of deaths occur in this age group here, but they make up the minority of cases, right? If you look at the people who make up the cases, that age group makes up the smaller amount of cases, but they make up the majority of case fatality. If you took out the elderly, the case fatality in the United States would probably be around half of 1%. Let's look at our testing in Florida. Saturday, there were 68,000 tests, of which 8.6% were positive. Now, we're looking for a number that's under 5% to try to get to some normalcy here. Why are we getting such a high percent? Well, it can only be two reasons. We're having a lot more people get sick, or the people we're testing are sick. At the beginning of the pandemic, the worried well were getting tested. Somebody would say, I'm willing to stand in line at the ballpark of the Palm Beaches for 2 hours and get tested to see if I have COVID. That's not going on now. The people getting tested now, for all intents and purposes, have symptoms. And therefore, I think that's why our positivity rate is rising. Let's look at our beds in Florida. You also can see that our occupancy for beds is not bad. COVID ICU beds, not very bad. Our hospital beds for Florida, not very bad. Look at the COVID. The COVID's the orange. 3,400 beds out of our 57,000 beds in Florida hospitals are occupied with COVID patients. That's a small percent. That's around 6% of the hospitalized patient has COVID. So in a hospital of 500 beds, maybe 30 are in there with COVID. And I can tell you from my experience, a lot of these people is because you just can't move them out. They're in the ICU and they have nowhere to go. I have some people in the hospital who have, undocumented, have nowhere to go, and have been there for almost a year, but they count as a COVID occupied bed. So let's look at Palm Beach County. How many positive cases have we had in Palm Beach County? 136,000. And out of that 136,000, you can see that 2,700 have died, 6,600 have been hospitalized. If you look at the lower cases of Florida, as of Saturday, the median age in Palm Beach County, not Florida, is 35. 2% case fatality, 4% hospitalization. The majority of deaths occur in people over 65. If you look at what percent of deaths occur in people under 34, 1%. Of all of those deaths, 34,000 in Palm Beach County have died of COVID. That's why you see these people get on TV and say, wait a minute, if you're under 34, your chance of dying going to Starbucks, getting a coffee is greater than dying of COVID. But that's a problem. Just because you're not going to die of the disease doesn't mean you can't spread the disease. How about the testing in Palm Beach County as of yesterday? Well, as of Saturday, there were 4,100 tests, right? Of which this many were positive. Okay, this is actually the wrong slide. This is vaccines. I'm sorry. So then what's the ultimate effect of the COVID outbreak or the COVID pandemic? The ultimate effect, obviously, is death, disability, mental, social, and it's becoming more social and economic, and it's becoming disability and death. That's not to downplay disability and death. What's the salvation? Herd immunity. Now, you have two avenues to success. We can either let the entire country become infected, expect that 0.5% of them will die, so 0.5% of the 330 million people would have to die to get 100% herd immunity, or you can do it by preventative vaccines, or you can do a combination. Right now, we're doing the combination because we have 31 million infected people that we know of in this country. Now, what does herd immunity mean? Herd immunity means, depending on your basic reproduction number, the higher it is, the greater you need to have herd immunity to prevent disease. You can see that measles tops the list. To stop a measles pandemic, you have to make 90 to 95% immune one way or another. For COVID, it has to be somewhere around the 60 to 80%. Nobody really knows the exact number. I know Fauci says somewhere around 70, 80%. Nobody really knows the exact number. Now, how are we going to get there? Well, the only way we've ever changed pandemics in our world is sanitation and immunization. Nothing else really works to bring it to an end. And we do that basically by vaccines. And as we all know, there are two parts of the immune system, those that we are born with and hopefully maintain throughout our life. Although we know as we get older, because of diseases, because of medications, these wane, or adaptive. You adapt to what you get exposed to, either by antibodies or T cell immunity. Well, if you want to acquire immunity, you can either acquire it naturally by becoming infected or passively, naturally, from antibodies from your mother, placenta, breast milk, or you can acquire it artificially. And that's either by vaccination or by immune globulin. And we'll talk about convalescent plasma. Convalescent plasma is a good idea. But the problem with convalescent plasma is for most infectious diseases, we give it before you've been exposed. If you're exposed to a mother with hepatitis B and you're a newborn, we give you hepatitis B immune globulin the moment you're born. If you're traveling to a part of the world where hepatitis A is endemic and you have no immunity to hepatitis A and no time to get vaccinated, we give you immune globulin. But we've been giving convalescent plasma to people who show up in the hospital on day 7, 10, 14 with COVID, where the cat is out of the bag. And all the studies show that if you're going to use convalescent plasma, you need to give it within the first few days of active infection. And we know that people don't develop symptoms until 5 days after they develop active infection. Therefore, we're always working from behind the 8 ball here. So that's why convalescent plasma hasn't panned out to be quite what it is. Now, what has panned out are the monoclonal antibodies. Because if you give it to people when they're mildly or moderately ill, meaning right when they get infected and they haven't gone on too far, that seems to be very effective. It's not given if you're admitted to the hospital, because by definition, you passed the stage of mild illness. So we're really aiming for vaccination here. Now, how do vaccines work? Well, actually, vaccine is a misnomer. The real term is immunization. We're making your immune system work like it did if it recognized the organism from natural infection. The word vaccine, as you may know, comes from the word vaca, which is because the smallpox, actually, that vaccine, way back in the 1600s, the Chinese recognized that people who recovered from smallpox, if you injected that serum from their pox lesions into other people, that fluid, they became immune. They didn't get the disease. And then even now, the smallpox vaccine that would be used is vaccinia. It's cowpox. And cowpox is how we got the word vaca for vaccine. So what is the whole purpose of vaccine? It's to generate immunologic memory without getting the disease, without getting sick. So to create illness without actually becoming ill. So then coronavirus vaccines got underway, and unfortunately they were called warp speed. And in this JAMA article in August 2004, 2020 on August 4th, they didn't take offense to the warp speed. Warp speed doesn't mean that we're going to do this halfway. Warp speed means that we're going to take every resource we have, our best scientists, our old science, our new science. We're going to throw a lot of money at this, and we're going to do this quickly. Because if we don't, we're going to have a lot of illness, a lot of death. We're not going to have a country to come back to. And that's why it's called warp speed. And at the beginning of the warp speed initiative, the government said, we're going to look at 5 vaccines who seem to be ready for phase 3 trials. The Moderna, the BioNTech Pfizer, the Merck Sharp and Dohme, who abandoned their vaccine trial for COVID, the Johnson & Johnson, and the AstraZeneca. So we're really dealing with 4 of them right now. Now, messenger RNA vaccines, which are the Moderna and the Pfizer vaccines, are not new to this world. Messenger RNA vaccines have been looked at since the 1990s. Now you have to ask yourself, we've been looking at these things for almost 3 decades. How come we don't have a human messenger RNA vaccine? Well, the reason for that is because they never panned out to be extremely useful. And part of it is not because they don't produce a good immune response. Part of it, as you've learned, is because they're very difficult to use in general public. And most vaccines in general public are given in doctors' offices. And this is a very difficult vaccine to make, these messenger RNA vaccines, because of stability. They're easy to produce. They're not easy to store and distribute. So we've looked at them for CMV. We've looked at them for Zika. They look pretty decent for Zika, but Zika fortunately went away, and the companies who were making this sort of abandoned the idea. Well, the messenger RNA vaccines are a little bit different than the viral vector vaccine. The viral vector vaccine, we do have a human viral vector vaccine. That's what really helped out Ebola in Western Africa, is that the Merck Sharp and Dohme people spent 4 years making a viral vector vaccine using a stomatitis virus for a very effective Ebola vaccine. Now, why don't we know about it? Because it's not useful in the United States. It's useful in other parts of the world. So you don't see very many people in the United States getting a viral vector Ebola vaccine. Now, how do these work? There's nothing in these vaccines that has the COVID virus. What these vaccines both have is the spike S protein right here, the glycoprotein on the surface, which is what attaches to our respiratory tract. So the purpose of these vaccines is to introduce that spike protein to our immune system, make antibodies to that spike protein, and those antibodies will block that spike protein when we get exposed to the virus naturally, so it doesn't take hold on your epithelial angiotensin converting enzyme 2 receptors in your respiratory tract. That's where this takes hold. Why do kids seem to get less sick? Because they have less receptors. I had somebody tell me today that they have a relative who cannot get infected with COVID because they genetically can't get infected. That would mean to me they don't have any of these receptors on their epithelial cells in the respiratory tract, which makes no sense at all. Now, the difference with the viral vector vaccine is you're actually taking a virus, in this case an adenovirus. With the Johnson & Johnson, it's a human adenovirus. With the AstraZeneca, it's a chimpanzee adenovirus. Either way, you cannot become infected with that adenovirus. And what they do is they attach the spike protein to the adenovirus. It gets injected, it enters your cells, your cell recognizes it as foreign, it makes a T cell response, the T cells initiate the B cell response, and you make antibodies to the spike protein. What I like about the viral vector vaccines, not to say I don't like the messenger RNA, is that I'd like the T cell response because we really depend on our T cells to initiate B cells to produce antibodies when we get re-exposed to a pathogen, whether it's bacterial or viral. That's the difference between the messenger RNA and the viral. They both produce antibodies to the spike protein. They don't produce antibodies to the nucleocapsid. So if you wanted to test somebody for natural COVID infection, you would order a nucleocapsid antibody titer. Well, the first vaccine to come on the market in December by an EUA. Let's explain an EUA. In 2001, after anthrax, the United States government said, hey, look it, we don't have good anthrax medications. We don't have good anthrax vaccines. We have to have a way for this government to approve these things before we go through our usual FDA inspection, before we cross all the T's and dot all the I's, which usually takes 4 years. We don't have 4 years. So we need some way to look at the data and to provide an emergency utilization access or authorization, EUA. Therefore, they say that if we find out that this Pfizer BNT, I really feel bad that the BNT company, look at their stock on the stock exchange. I feel bad that the BNT company doesn't get the name. It's really their vaccine. Pfizer just helped them make it. But if you look at this vaccine trial, very shortly after the vaccine trial ended, they presented their data to the FDA, and the FDA said, we think there's enough benefit in this vaccine that we will authorize an emergency use. That doesn't mean the trial's over. The Johnson & Johnson vaccine that got put on pause is exactly what was done, what's supposed to be done with an EUA, meaning we're going to look at this for 2 to 4 years. And during that period, if we start to see any concern, we're either going to stop it, withdraw it, or pause it. Well, they paused, as you know, the Johnson & Johnson, which I'll get to in a second. So if you look at the Pfizer trial first, they had approximately 37,000 people divided 50-50 between placebo and vaccine. When you look at their makeup, you know, it's very important to have diversity. So they had the diversity they thought they should have. They had, representation for these groups of people, although you could say, well, the African Americans in this country make up more than 9.2% of the population. Why only 9% in both arms? And we all know that there's a lot of African American folks who just do not want a vaccine for various reasons that are quite valid. So if you look up the makeup, the FDA said, okay, we have enough people who are over 55, we have enough women, we have enough men. We have enough people to say that we can actually look at the study and think it's representative. Now, remember what I said here, only 18,000 people got the vaccine. So all of a sudden, if you see a J&J vaccine paused, well, 7 million people got the vaccine. And the trial right here for Pfizer, only 18,000 people got the vaccine. So if you're going to see side effects or adverse reactions, obviously you're going to see them as it starts to get used in the real world. And the FDA is going to keep looking at that real world data, because when you go to Publix and get a vaccine, you are the trial. Even though you think you didn't enter a trial, you entered a trial. Those people who now all of a sudden got paused for the Johnson & Johnson vaccine are part of that trial. They just didn't enter the original trial. This was the data for Pfizer. Now, it's very important to look at something. You could say, well, how good's the vaccine? And everybody walks around saying, well, it's 94% for Pfizer. And I say to them, 94% what? They don't know. It's 94% efficacious at the primary endpoint. In other words, what were you trying to primarily prove? They were trying to primarily prove that by getting 2 doses of this vaccine, 7 days after your second dose, we can prevent PCR confirmed symptomatic COVID. If I would say to you, well, how many people out of that 18,000 got asymptomatic COVID? Trust me, quite a few. I know that because I'm the principal investigator for the AstraZeneca and the Johnson & Johnson, and I know exactly how many got asymptomatic COVID. How many people got the secondary endpoint? The secondary endpoint was, okay, we prevented primary COVID. Let me go back here. I'm sorry. We prevented our primary endpoint 94%. In other words, out of all the people, 8 got COVID symptomatically who got a vaccine versus 162 who got placebo. When did that start to take effect? Well, that's why they say 7 days after, right here, 7 days after your second vaccine. For Pfizer, the second vaccine's at 21 days, because the lines don't really separate until here. They don't statistically separate until here, meaning, do you get some benefit here early on? Yes, but it's not the percent that they're quoting. That's why it's 7 days after your second vaccine. Well, here's what they also said. Safety and efficacy beyond 2 months is not included in this. We didn't include people under 16. I can't tell you about pregnant people. There are no immunocompromised people, et cetera, et cetera, et cetera. Well, all of a sudden you go to Publix and you're pregnant. All of a sudden you go to Publix and you're on a Humira. All of a sudden you go to Publix and you're a transplant patient. You were not included in this trial. So the real world data is always going to look different than the data that you see here. In other words, is it 94% effective in somebody who's on a medication for the rheumatoid arthritis? The answer is, I don't know. They weren't in the trial. Can pregnant women be safely vaccinated? The answer is, I don't know. They weren't in the trial, etc. Can children be vaccinated? The answer is, I don't know. They weren't in the trial. Well, how about if I said to you, okay, wait. So the vaccine protected you against symptomatic COVID. How did it do for asymptomatic COVID? What's their answer? I don't know. That wasn't part of the trial. They have that data, but it wasn't their primary focus in the trial. If you asymptomatically get infected and you got a vaccine, can you still transmit it? Their answer is, I don't know that. Now, to tell you the truth, I do know that for the AstraZeneca trial, because I'm going to be one of the authors on the New England Journal article that we're writing right now. So I've seen the final data for AstraZeneca, and I do know those numbers and I do know those answers, but unfortunately I'm sworn to secrecy. And if I tell you, I'll no longer be an author. So when you see that come out in the New England Journal, not too far from now, you're going to have that information. So then how about the efficacy? How about the efficacy for the Moderna vaccine? Basically the same thing, somewhere around 94% efficacious for their primary endpoint, which is symptomatic COVID. How about asymptomatic COVID? You know, a lot of people got asymptomatic COVID, but that wasn't their primary endpoint. But it still was very effective. And you can see that's separated by 28 days. And look where the lines start to separate. Look when placebo starts to separate from vaccine, meaning that you can't count yourself as safe for symptomatic COVID until 2 weeks after your second dose, which puts you out here. Same thing. What's the long-term safety? They say, I don't know. The FDA approved it after 2 months. How about asymptomatic? They say, we don't know. We'll find that out, et cetera, et cetera, et cetera. How about the side effects? Well, look at Moderna, look at Pfizer. Look at fever, headache, myalgia. Look at mild, moderate, severe, second dose. Fever, first dose, basically not too much. A lot, second dose. Same thing here. There seemed to be a lot more fever with Moderna than there was with Pfizer. From the real world experience, the people I talked to seem to have a hard time with the second dose of Moderna, not so much with Pfizer. You know, even though these are both messenger RNA vaccines, the lipid molecule that's putting them together is slightly different, as are some of the other components of the vaccine, and that may account for the higher side effects on the second dose of Moderna. Now, the Johnson & Johnson, as I told you, is a viral vector. They know that one-dose vaccine. Now, why is there a one-dose vaccine trial? I'm the principal investigator for our two-dose vaccine trial. Once the one dose got FDA approved, EUA, not totally approved, EUA, we unblinded everybody, and anybody who got a placebo, we vaccinated. That was a lot of people. That took a lot of effort. You can imagine, they all wanted vaccine yesterday. What was the primary endpoint? 71% of people who got one dose of J&J were protected against symptomatic COVID. But most importantly, they were all protected against severe disease or death. That's the same across the board for all the vaccines. Now, what happened? The FDA approved this for EUA. Why do they say 66%? Because it was a little bit lower in people over 60, a little bit lower. But if you look down here, you can see that in the United States, the vaccine efficacy was 72%. It was a little bit lower in Brazil, a little bit lower in South Africa, and that's why they get to 66%. Again, it's for people between the ages of 18 and 59. The adverse events didn't seem to be that bad. But then all of a sudden last week, what happened? The FDA withdrew or paused the J&J vaccine. Why is that? Because out of almost 7 million people who got the one-dose vaccine, you could ask, why are they doing a two-dose trial? Because they believe the numbers will be greater with 2 doses than it is with 1 dose. The reason they did the 1-dose trial was because we're in a pandemic and they wanted to have something to offer the world early on that would be efficacious before they were able to complete the 2-dose trial. Out of the 7 million people in the real world experience who got the 1 dose, last week, there were 6 reported cases, all in women this age group, with clotting diseases. Some of these were cerebral venous thrombosis, central venous thrombosis. One of these folks died. Some of these were pulmonary emboli, deep vein thrombosis, and thrombosis in the GI tract, in the vessels in the GI tract. What they did learn is it seems to be an immunologic reaction where you form an antibody against platelet factor PF4, which is just like the heparin-induced thrombocytopenia. So therefore, if you had a patient with this event, the recommendation is don't anticoagulate them with heparin. Now, is this a big deal? Well, as you know, about a month ago, the AstraZeneca vaccine, which is currently being used in 80 countries in the world, 2 doses separated by 4 to 8 weeks, also had problems with thrombosis. Out of 17 million people, 37 developed thrombosis due to numbers. You can still get Guillain-Barré from the flu vaccine, but it's much less than getting it from the flu itself. So the World Health Organization and the European nation, which basically has their own form called the EMA, which is like the FDA, said that we're going to give a warning for the AstraZeneca vaccine. We're not going to restrict it, but we're going to warn people that there is a slight chance of a thrombosis from the vaccine. Now, the FDA has put the J&J vaccine on pause, and this coming Friday, they're going to relook at all the data and they're going to make a recommendation. There's three things they could do. They can withdraw the EUA, and that will be the end of this vaccine. Number two, they can give a warning and say, we don't have any firm recommendation, but you should warn your patient, called the package insert. Next time you go to a pharmacy and pick up a drug, read the package insert to tell you there's a chance of ABC. Or they can restrict it to certain people and certain age groups. Let's put these thromboses into perspective. AstraZeneca vaccine, 4 cases in a million vaccinees were a percent of 0.0004. Birth control pills, 500, 1,200 cases in every 1 million women taking a pill, 0.05 to 0.12, multitudes higher than this. Smoking, the chance of deep vein thrombosis, pulmonary embolus, 1,763 for every million smokers. How about COVID infection itself? 16.5% chance you will develop a thrombosis somewhere in your body. In fact, the FDA, IDSA, CDC, NIH guidelines say that if you're admitted to the hospital with COVID, you should be on prophylactic doses of Lovenox. How about the AstraZeneca vaccine? As I told you, it's a chimpanzee adenovirus. You can't get infected from the adenovirus. You can't get infected from the vaccine. In this trial, we enrolled 32,200 people, of which 2/3 got vaccine, 1/3 got COVID. Now you can ask, why was it 2-to-1 here and 1-to-1 in the other vaccines? Frankly, because the sponsor wanted to encourage you to enter their trial and not the others so they can get their trial done. What are the advantages of this vaccine? The advantage is with the potential T-cell response. They all produce the same antibodies to the spike protein. I can't tell you the primary endpoint, but right now they're saying that the primary endpoint of symptomatic COVID was somewhere around 79%. I can't give you the number, but I can tell you it was even higher in people over 65. It was 100% effective in protection against severe disease. And of course, as I mentioned, there were thrombosis. I know the number for asymptomatic infection, the prevention, but frankly, I'm not allowed to tell you right now. So this vaccine is being used in 80 countries throughout the world. The sponsor, AstraZeneca, is getting ready to submit their data to the FDA for an EUA, which I think is going to happen briefly. So then what happened? Well, the ACIP said, okay, if we're going to roll out these vaccines, do you want to prevent morbidity and mortality, or do you want to preserve societal function? Well, if you want to prevent morbidity and mortality, you got to go after the elderly people in nursing homes. If you want to preserve the society, you have to go after the people who are likely to get it and spread it, which are the younger people out in the working world. Our country chose this method. And when they did that, they said, why are we doing that? We're doing that because of the elderly are dying. But the incidence of COVID is highest in the younger, right? It's the younger people who are really getting infected when you compare it to the older. Now, the mortality or the case fatality obviously is higher in the elderly. But if you look at across the board, who's dying, you can see that the overall mortality increases with age, but the proportion of deaths associated is similar because the proportion of people who get infected is greater in the younger. So yes, we're protecting the elderly, but we're in essence allowing disease to spread a little bit more than perhaps it should, especially when you now see that the median age in Florida is somewhere between 37 and 40. So that the phases were this. Phase 1 were this group down here, long-term care, elderly. Then we went to healthcare workers, frontline, essential workers, and as of today, anybody. The only vaccine that's authorized for EUA to 16 is Pfizer, but the trials are going on with the other vaccines down to the age of 12. So here are some of the considerations. Can you vaccinate kids? I just mentioned that. Can you vaccinate pregnant women? Well, the answer is discuss it with your OB, but the CDC's recommendation is do it. Why? Because we feel it's safe in pregnancy. Can you switch vaccines in the middle? The answer is you shouldn't do that. You should not get one vaccine and get another. Are we going to need booster doses? You know, I tend to think we're going to need booster doses for several reasons. If you've already had COVID, should you get vaccinated? The recommendation right now is yes, although the data is not out. How well are we doing to vaccinate the world? Well, this is international percent of people fully vaccinated by country. Gibraltar's doing the best. Israel's doing the second best. How we doing in the United States? In other words, what percent of our country has been vaccinated, fully vaccinated? As of yesterday, somewhere approaching 30% of our country has been fully vaccinated. Now, North America, how many people have been vaccinated fully? 88 million. How many in these different countries? The United States, somewhere fully vaccinated, around 70, fully vaccinated, right? Somewhere around here. Now, remember, we have 330 million people living in this country. So although we're looking pretty good up here, it's really still a small percent of our country, which you can see right over here. Now, as of the other day, fully vaccinated, the numbers switch because I'm getting the slides on different days. You can see it's around 84 million people are fully vaccinated. Around 40% have had at least one shot. If you get the people over 65, you can see that around 81% of people over 65 have had one dose. Around 66% have been fully vaccinated. And that drops off as you start getting down to younger people because we've been vaccinating the elderly at the beginning of this. If you look at the race to a vaccinated United States, who's doing the best? Believe it or not, Pennsylvania. Alaska, this is the percent of people fully vaccinated by state. What percent of Alaska has been fully vaccinated? Only around 33%. Do you see Florida here? Does that bother you? You don't see Florida. Why do you see Florida here? This is people who are fully vaccinated because we vaccinated in Florida as of yesterday, the number went up somewhere around 7 to 8 million people. But we have 23 million people living in Florida. We're the third most populated state in the country. So although it looks like we vaccinated a lot of people, percentage-wise, we haven't. So above the US, below the US, you don't see Florida listed over here, although you do see Florida here. So the best states for fully vaccinating their entire population are places where it's a lot easier to vaccinate. Places like South Dakota, Alaska, Vermont, Maine. It's a different demographic. It's a little bit easier for a lot of reasons to vaccinate. If you look at the states where the number of people have been fully vaccinated, it really falls off down here. And although Florida looks pretty good, a lot of these states are not nearly as populated as we are. So how have we done in Florida as of yesterday? Well, we've given 12 million doses in Florida. Remember, we have 23 million people living here. How many people have been fully vaccinated, right? Fully vaccinated. Look at here, completed a 2-dose series, completed a 1-dose series, 5 million. So 5 million people out of 23 million people as of this day and this time have been fully vaccinated in Florida. And you can see the majority of them are elderly. And it really is a concern to a lot of folks, including me, that the African-American population for first dose, complete series, totally vaccinated is really poor when you look at the percent of people in Florida who are African-American. Now, here's another interesting thing. Why is it more in women than in men? Because people working in the hospital tend to be more women than men. And they were originally part of the healthcare workers, or part of the original rollout. This is as of Saturday. There were 50,000 injections in arms on Saturday for vaccine. 26,000 were first dose, 24,000 were completing their second dose. This is what's going on in Palm Beach County as of yesterday. We've given less than 1 million doses. We have 1.4 million people living in Palm Beach County. We've given around a third of a million have completed a series. A third of a million, that's about 360,000, right? We have 1.4 million people living in our county. Again, you can break it down by age. They got vaccinated earlier. African Americans, again, first dose, second completed series. Only 19,650 African Americans have a completed series as of yesterday in Palm Beach County. There are 1.4 million people living in this county. That is really, really a low number. We got to really, really do something about that. If you look at Saturday, how many people got a shot in their arm? Only 5,000. 5,000 out of 1.4 million people living in Palm Beach County. Now, Saturdays, to be honest, are always less than the rest of the week for a lot of reasons. I'm not even sure Publix vaccinates on Saturday. And you can see that that makes up only the percent here. Actually, that's something else. So what do you do once you've been vaccinated? Well, if you go in your house and you have people over and everybody's been vaccinated, you can take your mask off. But if you're out in public, you still got to wear your mask, because vaccine does not mean you can't get asymptomatic disease and you can't spread it. And vaccine does not mean you can't get reinfected. And vaccine does not mean you can't get a variant. What hasn't changed? The outside rules. The social mitigation has not changed. There are too many people who still feel they've been vaccinated, they can go without masks and drop all the other precautions. And then all of a sudden we started seeing the variants. And the problem with the variants are that we really don't know how well these vaccines are going to hold up. Because if you think of it, when the Moderna and the Pfizer trial were conducted, there were no variants. When the J&J trial was conducted and the AstraZeneca trial was conducted, we started to see variants. And the variant that's most popular in this country right now is the B.1.1.7, which is the Britain variant. You don't have to go to Britain to get it, to New England, or excuse me, to England. The Brazilian variant seems to be the one that's most concerning, because that one may be more lethal. The others seem to be more transmissible. They seem to attach to our epithelial receptor cells better, but they don't seem to be more lethal or more, more infirm or create a larger illness. Are we going to need to upgrade these vaccines every year with new variants? We may. Are we going to need boosters? We may. Nobody knows. I know Anthony Fauci, is on TV a little bit too much these days, and he's become the voice of COVID. But he doesn't know the answer. And his answer is basically that, I don't know, we're going to see. But he's basically saying we may need new vaccines and we may need variants. So the question I get all the time is, am I safe if I have a vaccine? Can I go hug my grandchildren? Can I go golfing? Can I go to a restaurant, et cetera, et cetera, et cetera? Safe is an individual assessment. It's not a scientific thing. What is safe is really not following the science. It's really a political question. It's really deferring to the interests of and the opinions of everybody else who's involved here, which is every one of you and me and everybody else we're around. And Camus said it best in his book about the plague. And what he basically said is, then how do you ultimately get rid of this overwhelming human experiment, these pandemics? And basically what he said in this novel is, the only way to do it is decency. And doing decency is doing our job. And JFK said, are there risks and costs to action? Warp speed, vaccination, EUAs, medications that get approved rapidly without long trials? Of course there are. But they're far less than the long-range risks of comfortable inaction. And I know I went on a long time. I'm going to stop there and thank you for attending. And I'll end right there. So
thank you, Dr. Bush. That was amazing.
Well, thanks.
Can we share that on our website?
Absolutely.
It was good. Some of that was over my head. I need to re-listen. It was fabulous. Thank you. Thanks everyone for attending. And I hope to see you all on Thursday at the our program and Friday. Be well.
All right. Thank you all. Molly, get well quickly from your event.
Oh, wait.
Bye.
Bye.
Bye-bye.
Thanks, everybody.
Thank you.